Very good morning to all. Welcome to the clinical meeting. Today, Dr. Alex Reginald, a senior professor in medicine, has agreed to take clinics, and Nisheet will be presenting. Sir has been a professor in CMC in Department of Emergency Medicine and Chittoor. He actually initially worked in Chatram and then decided to come to CMC and stay here. He's passionate about teaching. So thank you, Dr. Alex, for coming. He's come within his busy schedule because he's saying he has to go back now to see his OPD. So we will go on to the session. Thank you so much for coming, Alexa.
Good morning, everyone. Today I'll be presenting. I'm Dr. Nisheet. Currently, I'm working in Chittoor CMC Hospital in Chittoor campus. I'll be presenting two short cases today. The first case is Mr. A, 40-year-old gentleman. He's a farmer by profession, residing in Palasa, Andhra. He doesn't have a history of any diabetes, hypertension, or hypothyroidism. Significant history: he had a cerebrovascular accident 6 years back when he had developed sudden onset left-sided hemiparesis. It was diagnosed to be an ischemic stroke, and he is currently fully recovered with no residual deficits. At the time of illness, he was told to have some cardiac illness at that time, and there was no history of any dyspnea, palpitation, orthopnea, or PND throughout the course of his life. Coming to examination, he was conscious, cooperative, oriented to time, place, and person. Height was measured to be 160 centimeter with a weight of 52 kilograms. BMI was coming up to 20.3 kg per meter square. There was no pallor, icterus, clubbings, lymphadenopathy, or pedal edema. The temperature was 98.9 degree Fahrenheit at the time of examination. Respiratory rate was 16 per minute. It was abdominothoracic pattern with no use of accessory muscles. Saturation at the time of examination was 98% in room air. General examination, blood pressure was measured in supine position. Right upper limb blood pressure was noted to be 98 by 66 milligram of mercury. Left upper limb was noted to be 102 by 61 milligram of mercury. Right lower limb was measured to be 108 by 70 milligram of mercury, and left lower limb was measured to be 104 by 70 milligram of mercury. Pulse rate was 80 per minute. It was irregularly irregular. Heart rate was measured. It came to 94 per minute. The pulse deficit was noted to be 14 per minute. The pulse was normal in volume, normal in character, and all peripheral pulses were present equally. There was no radial or no radiofemoral delay. Jugular venous pulsation was not visible. There was no peripheral signs of infective endocarditis. There was no dysmorphic features or stigmata of any congenital heart disease. Coming to systemic examination of the cardiovascular system, inspection: chest was bilaterally symmetrical. Trachea appeared to be in the midline. There was no spinal deformity, no kyphosis or scoliosis, no visible scars or dilated veins were present, no precordial prominence was noted, apical impulse was not visible, no pulsation was visible in the epigastric, suprasternal, or aortic region. On palpation, trachea is in midline. Apex beat was felt in the fifth intercostal space in the mid-clavicular line. It was tapping in nature. There was a left parasternal heave which was present along the left border of the sternum. There was a palpable P2 in the left second intercostal space. There was no epigastric pulsation, no palpable heart sounds, and there was no palpable carotid thrills. Percussion: left heart border was corresponded to the apex beat, and right heart border was at the right sternal border. On auscultation, apex first and second heart sounds were heard. There was a loud S2, a rough rumbling, low pitched and mid diastolic murmur of grade 3 by 6 heard with the bell of the stethoscope, with an opening snap, with the patient put in left lateral position with breath held in expiratory apnea. Auscultation in the aortic area, first and second heart sounds were heard. There were no murmurs. In the pulmonary area, first and second heart sounds were also heard. There was a loud P2. Tricuspid area, first and second heart sounds were heard. No murmurs were heard. Rest of the systemic examination, Respiratory system, there was there was normal vesicular breath sounds heard, no added sounds. Abdomen was soft, non-tender. No hepatosplenomegaly was there, and there was no free fluid. CNS examination wise, currently there was no focal deficits. Cranial nerves were normal. Bilateral upper limb and lower limb power were 5/5. All deep tendon reflexes were positive. Plus 2+. Bilateral plantars were flexors. At the end of summarizing the summarizing the case, he was a middle-aged gentleman. Was noted to have irregular pulse with a normal volume. Apical impulse was felt in the fifth intercostal space in the mid-clavicular line. There was a loud S1 in the apex and a mid-diastolic murmur in the apex, grade 3/6, and a loud P2 with a palpable P2 was present in the pulmonary area. With this examination finding, the final clinical diagnosis which I came to conclusion is it was a univalvular heart disease involving mitral area in the form of mitral stenosis, likely etiology to be rheumatic heart disease. And there was evidence of pulmonary arterial hypertension, and he was in atrial fibrillation. There was no evidence of any heart failure, and there was no evidence of no signs of infective endocarditis.
Okay. So thank you, Nisheet, for the presentation. Some of the doubts. So when somebody said that he presented with stroke in the past and presented with, somebody told them that he had a cardiac illness. So what are the things which came to your mind?
So the first thing with a stroke with some cardiac illness, the first thing which would come into mind is a young guy with no known comorbidities. First likely diagnosis would be a valvular heart disease or an atrial cardiac arrhythmias, which might have caused embolic stroke.
Okay. Any other differentials will come to your mind? Or this is the only diagnosis, rheumatic heart disease with valvular involvement? Or what are the differentials you can think of?
So the stroke could be some hemorrhagic bleed.
In other words, what are the causes of young stroke?
Yes, it could be aneurysmal bleed, which can.
No, you have to tell the commonest, according to the commonness. In medicine, that is very important. As a clinician, you have to list down according to the commonness.
So hypertensive.
Hypertension.
Yes, sir. Hypertension.
But he said that there are no comorbidities. Do you have a list of diseases or causes of young stroke? Anyone can answer. Okay, see, you got it, no? You got the question. Thing is, he is a young guy. Now he is 40. When he had the stroke, he was around 33, 34. Now, he presented with the stroke at the age of 33. All right. See, previously, when we were doing medicine, that is the diagnosis, rheumatic valvular. Now, because that was so common as those days, now rheumatic fever and rheumatic heart disease is not so common. So, what are the other things you should think of? Or you just list down the causes of young stroke? Hyper homocystinuria. How common it is, man. Okay, see, in medicine always try to classify infection, infiltration, inflammation, endocrine, all they list down the causes, metabolic, degenerative, so like that. So what are the other next commonest is? The next commonest is? See, in India, which is the commonest?
Infection.
Infections. So which infection comes to your mind? Tuberculosis. Okay. tuberculosis, how do they present as a stroke? TB, vasculitis. So here is a short case. We cannot discuss all that. So just quickly, let me, tell me the causes at least. No, may not be possible in this patient, but you should have the list. So tuberculosis. What are the ways TB can affect the brain or CNS? What are the ways it can affect the central nervous system? What Vivekanandan, tell me. Infective emboli. Okay, since you have mentioned that, emboli, what? That is, he has already told. Infective emboli means, what do you mean by that? Infective endocarditis. Okay. Anyway, please, for the want of time, I am just moving on. You have to please have a list of the causes of young stroke. Okay, infections, inflammation, the inflammatory disorders present like stroke. See, TB, another question is, what are the ways it can affect CNS? Tuberculosis, vascular disease, tuberculosis, end arthritis, tuberculomas, okay, arachnoiditis, may not be stroke, it can present like this, basal meningitis. So please, you should have a list. So that's infection. Inflammation, all the inflammatory disorders, SLE, rheumatoid arthritis with CNS involvement. Okay. Anything else? Space occupying lesions. What is the commonest? Even tuberculoma is one of the kind of space occupying lesion. Right. The next, what are the SOLs? In a young patient, what are the things you should think of apart from malignancies? Space occupying lesion. Abscess. Brain abscess. Cysticercosis. Anything else? Usually they present like seizures. Strokes are not very common, but of course possible. Aneurysms. Which aneurysm? Young people, especially females, they present with berry aneurysms. Okay. So berry aneurysm can present like a space occupying lesion and they can bleed and so you should have a list of the commonest causes or the causes for young stroke. Okay, so don't just think of rheumatic valvular heart disease. So tell me, what are the evidence of rheumatic valvular heart disease in this patient? Right from the history, you would have taken the history, no? But what are the evidences for rheumatic heart disease in this patient?
In this patient particularly, sir.
Just louder, no?
So in this patient particularly, he did not have any history of any fever.
Okay, so what are the histories you will ask?
So first, history from childhood, I will ask if there is an history of any fever or recurrent episodes of lower respiratory tract infection, if he is getting or not. Second, if there is any limitation of his activity, like he was not able to do as much of activity as other people in his age could do. There's any history of cough, breathlessness.
No, specific to rheumatic valvular heart disease.
Breathlessness and exertion.
Okay, history of rheumatic fever, you say that. So what question you will ask?
So anytime he was admitted with sore throat followed by breathing difficulty and lower respiratory.
And what else? What else?
And chest.
Rheumatic fever, man. What history you will ask? Rheumatic fever. Please, you are all medicine PG. You should be very specific. It's a migratory polyarthritis. Okay, fleeting type of polyarthritis. So migratory polyarthritis, history of migratory polyarthritis. What else? Anything else they can present like? You may not get the history. Maybe very less than 30% will have the typical migratory polyarthritis. Anything else you will ask for? Rheumatic fever. How do they present? in other ways of presentation? What is that? What? Pseudonym scoria. Okay. So some patients you get the past history of chorea, pseudonyms, typically pseudonym scoria. Okay. Please remember all these things. There is no migratory polyarthritis. You should also ask for typical history of chorea, pseudonym scoria. Okay. Did you ask that history?
Synonyms.
Yeah, because you never thought about it. Okay. So what are the other evidence of rheumatic heart disease in this patient? See, when you want to connect it with the stroke, so these are the things you should carefully think for. Okay, so the history wise, you should ask for rheumatic fever in the past, the migratory fleeting polyarthritis, pseudonym scoria. Okay, examination, anything? Is there any other rare way of presentation of mitral stenosis? Today, you are talking about mitral stenosis, no? If it is mitral stenosis, any other rare way, it is very rare, but they can present. I have seen patients. My DNB medicine case was that. So that's why I can remember that. So what is that? Just tell me, if you, any other way of, if it is mitral stenosis, predominantly. What is Ortner's syndrome? What is Ortner's? Ortner's.
Due to LA enlargement, there is.
What? Compression of the. So how do they present? Hoarseness of voice. Okay. So somebody can present like that also. Please remember, especially mitral stenosis, predominant mitral stenosis, if they present with hoarseness of voice, sometimes they may not even complain because they would have had it for a long time. Or, that is not their main complaint. Okay. So, hoarseness of voice, any voice change because of the left atrial enlargement and compression of the recurrent laryngeal nerve. So they can also present. That's called Ortner's syndrome. All right. So these are the ways they can present. Right. Examination. What are your evidences?
Examination. Cardiovascular examination, sir.
Just tell me the evidences for rheumatic heart disease in this patient.
The apex feet was felt at.
Apex feet was not shifted anyway.
Not shifted, but it was tapping in nature.
Okay, you had a tapping in nature. What do you mean by tapping?
So it is due to the loud S1.
It's a palpable
S1.
It's a palpable first heart sound. Okay. So what is hemic and hyperdynamic? What is the difference between hemic and hyperdynamic?
So heaving, it's a
heaving and hyperdynamic.
So heaving is a sustained impulse which is due to increased force.
Yeah, the difference is the amplitude. It lifts your finger and stays there for some time and goes down from the axis. That's the difference. So where do you get it?
So in heaving, we get it in condition aortic regurgitation and LV.
Don't mug up. Heaving is due to, what happens to the heart. It's a muscular, it's a hypertrophy of the left ventricle. Whereas aortic regurgitation, the main thing is the left ventricular volume overload, so dilatation. Okay, so that's the difference. So don't try to mug up. Heaving, it is aortic regurgitation, but you should know why. Okay, so here the evidence is he has a tapping apical impulse. So that is one reason. What else?
So he also had a left sternal.
Left parasternal heave.
Yes, past.
Left, anywhere else you get parasternal heave.
So in right ventricular hypertrophy we can get.
Okay, so left atrial enlargement or right ventricular hypertrophy. Okay, Both can happen in mitral stenosis. What else? Any other evidence?
He had a palpable P2, which is
Okay, palpable P2 suggests what?
pulmonary artery hypertension.
Hmm?
Pulmonary hypertension.
It's a pulmonary arterial hypertension. See, be specific. In medicine, that is very important. It's not pulmonary venous, it's a pulmonary arterial hypertension, which you are feeling. Okay, what else?
And on auscultation, he had a loud S1 and an opening snap with a mid-diastolic murmur.
Okay, so he has an opening snap, he has a loud S1
Yes, sir.
and
Mid-diastolic murmur.
mid-diastolic murmur. It's a rough rumbling mid-diastolic murmur. Okay, definite. If you get these findings, there is no doubt about it. If it is a mid-diastolic murmur, rough rumbling murmur, it is nothing other than mitral stenosis. So, all right. So, is there any differentials for mid-diastolic murmur in the apex? Otherwise, what are the causes of? See, these are the exam questions. You cannot make mistakes. Please. Sometimes you have to mug it up. Causes of mid-diastolic murmur in the apex.
Due to aortic regurgitation,
Hmm?
it can have early aortic regurgitation.
Aortic regurgitation. What is the murmur called? What is that murmur called? No, it should be on your fingertips. Okay. Austin Flint murmur. Okay. What else? What is Caricum's murmur? Caricum's. People have to read, man. Okay. Caricum's is traumatic valvulitis. Okay. People should be confident because you cannot make mistake. These are all basics. So Caricum's murmur is rheumatic valvulitis, acute rheumatic valvulitis. What are the other things? What are the other differentials? What are the causes of MDM in the apex? Any flow murmurs? Flow murmurs. ASD, VSD and PDA. Okay, ASD, VSD and PDA, especially when there is a right to left shunt. Why it happens? Why it happens? Because there is a left to right to left shunt. See, there is no mitral stenosis, but because of the shunt, the volume of blood is more for the valve. It's like a relative stenosis. You understood what I'm saying? Large volume of blood is trying to go through a fixed valve. So it's like a mid-diastolic. It's like a mitral stenosis. Okay, so don't try to mug up things, just understand and read. So these are the causes of MDM in the apex. So see, as a medicine PG, you should go to the next level of thinking. Okay. And there are certain diseases which can mimic like mitral stenosis. They are not very common, but there are some diseases. It's not a valvular disease. What are the other things?
Left atrial myxoma.
Left atrial myxoma. These are common questions everybody should know.
Infective endocarditis with
Okay, valvular thrombus. Okay. So please make a note of these things. You have to go back and study this all. If you get an MS case, they will ask all these questions by exams. But anyway, when clinically also, when you manage, you should think of all these things. Okay. So now you sort of told, this is a case of mitral stenosis. Okay. And the reason for the stroke is?
Atrial fibrillation.
Because he has an underlying atrial fibrillation. So what are the changes can happen to the to mitral stenosis in the presence of AF. Especially when you auscultate.
There is pre-accentuation of the pre-accentuation of the murmur before the
Start from the sounds, man, always. Then go to the murmurs. Start with the heart sounds.
It could be soft as there could be a soft S1 in
S1 will be
soft.
not soft. It will be variable. Variable intensity of S1. What else?
The opening
Opening snap
snap will be absent.
may disappear. Okay.
And then
And
pre-accentuation of the
there is a loss of pre-systolic accentuation. Pre-systolic accentuation will be lost. Okay. Yeah, already is 10:25. Okay. Any MS can be associated with any other cardiac disease. I don't know whether you heard about it. What is Luton-Backus syndrome? Luton-Backus. ASD with ASD with MS. Okay, ASD with MS. Is it a primary? Sorry, primary ASD or secondary ASD? Is it acquired mitral stenosis or congenital mitral stenosis? You should be very specific. Okay. So there is ASD. There are two types, ostium primum and secundum. So here it is ostium primum or secundum. Same way, mitral stenosis can be congenital, but usually they don't survive till adulthood if untreated. Any idea? Okay. So Luton-Backus is the ostium secundum type and the rheumatic in origin. So it's a very rare disorder, but MS can be associated with ASD. Okay, we'll just quickly go to the management. How will you manage this patient?
So depending on if they are symptomatic or asymptomatic, and we will do an echo to find out what is the severity of the mitral stenosis.
Don't directly go to echo. No, there is an order. So what will you do first? Apart from counts and all that, leave it. It's not important. But specific tests. You will do an ECG to look for what?
Left atrial fibrillation.
Atrial fibrillation. What else you see in the ECG?
Evidence of left atrial enlargement.
Left atrial enlargement.
And
and right ventricular hypertrophy. You can get RBBB patterns. What about X-ray?
So X-ray, there won't be cardiomegaly. So the apex bit would be.
So what are the X-ray findings in MS?
There is no cardiomegaly. There is straightening of the left.
There is no cardiomegaly. I'm not talking about this patient. In general, what are the things you will look for? Carefully, you look for.
So left heart straightening of the left heart border.
Okay, straightening of the left heart border. What does it suggest?
Left atrial enlargement.
Left atrial enlargement and pulmonary arterial hypertension.
And
what else?
Speaking of the carina of the
Okay, all these things you should know. You cannot think so long. Shadow in shadow, curly A, curly B lines. Okay, upturned mustache sign. See, all these things we should be very thorough. You cannot make mistakes. How will you treat this patient? Okay, so echo. This patient, any echo was done?
Yes, sir.
So what do you look for in the echo?
So the mitral valve area. So
mitral valve orifice. So what is the orifice? And what else you look for, man? Echo. There is some score, no? What is that?
Welkin
Some
score.
score.
Welkin score.
What is that?
Welkin scores.
Welkins score. There's some score you look for. So basically you look for the, calcifications, the pliability of the valve, the thickness. So that is Welkin score. If it is, what is the score like?
If it is more than 8, there won't be much benefit with balloon valve.
So if it is more than 8, so the surgery will be necessary. You cannot do a balloon, BMV. If it is less than or equal to 8, you can go or
balloon valve, balloon
balloon mitral valvuloplasty or commissurotomy. Okay. Okay, I think we don't have time to discuss much more. So these are some of the exam questions. I quickly covered, but your thinking process should be a little more wider. Okay, and also people should read about some more theory, because these are the questions they will ask in the exam. And if you don't answer, they'll think that you don't know anything. Okay, you may know how to treat the patient and all that, but if you don't know these answers, you may not succeed. So you'll have to be very careful. Okay, right. You can go to the next one.
Next patient, it's a Mr. P, 46-year-old gentleman, an ex-army personnel working as a security guard currently. He's a chronic alcoholic for the last 20 years with no known comorbidities, presented with fever for the last 7 days with abdominal distension with yellowish discoloration of the eye for 7 days. General examination, the patient was lying in reclined position in the bed. He's conscious, coherent, cooperative and obeying commands and is in mild distress. He's thinly built and poorly nourished. Height was noted to be 164 centimeters, weight 72 kgs, the BMI of 26.8 meters square. General examination, pulse was noted to be 110 per minute in right radial artery. It was normal in rhythm, normal in volume, character. No vessel wall thickness was present. There was no radial radiofemoral delay. All peripheral pulses were felt. Blood pressure was 100/60 in the right arm in inclined position. Respiratory rate was 28 per minute, regular abdominothoracic pattern, and there was use of accessory muscles of respiration. Temperature was noted to be 100.9 degree Fahrenheit at the time of examination. Jugular venous pressures was not elevated. Hepatojugular reflex was absent. General examination, pallor was present. Clubbing, cervical lymphadenopathy and axillary lymphadenopathy were not present. Icterus was present. Pedal edema was present up to the mid shin with associated with pitting. There was good oral hygiene. We looked for signs of liver cell failure. There was no alopecia, no white hot spots, no conjunctival hemorrhage, no xanthelasma, no medial supraciliary macronosis. There was shrunken eyes was present, loss of facial hair, and also loss of axillary and pectoral hair with loss of pubic hair was present. There was no bleeding gums, no factor hepaticus, no spider nevis, no Dupuytren's contracture, and no flapping tremors or asterixis were present at the time of examination. General examination, there was no peripheral signs of tuberculosis. There were no peripheral signs indicating of an internal malignancy. Abdominal examination, inspection, abdomen appeared to be uniformly distended and flanks were full. Umbilicus was everted and appeared to be in the midline. All areas of the abdomen were moving symmetrically with respiration. There were no dilated veins, visible masses, scars, sinuses, pulsation or peristalsis, which was noted. There was no divarication of recti. Hernial orifices were free. Superficial palpation of the abdomen. Abdominal girth was noted to be 109 centimeter with xiphisternum to umbilicus length of 22 centimeter. Umbilicus to pubic symphysis is noted to be 18 centimeter. Bilateral spino-umbilical distance is noted to be 21 centimeters. Abdomen was warm to touch. There was no superficial tenderness present. Deep palpation. Liver was not palpable. Spleen was palpable in the left hypochondrium with smooth surface was smooth, non-tender, extending 3 centimeter from the left costal margin. Notch was not palpable. There is no augmental thickening palpable. No hernias were present and no other palpable mass were present. On percussion, liver dullness was noted to begin from the fourth intercostal space. Tidal percussion was present. Liver span was noted to be 10 centimeters. Drop space was dull to percussion. Shifting dullness was present with fluid thrill. Auscultation, bowel sounds were heard 3 to 4 per minute in the right iliac fossa. There was no bruit or venous hum that was noted. Per rectal examination, there was no perianal skin tag. Anal splinter tone was normal. Rectum was empty. There was no blood in the examining finger. There was no prostatomegaly. Other relevant system examination finding, apex feet was felt at left fourth intercostal space with mid-clavicular line. With S1, S2 was heard normally. There was no S3, S4 or pericardial rub. Respiratory system, trachea was central, chest wall was symmetrical, bilateral air entry was present. There was absent breath sounds in bilateral infrascapular region. See, central nervous system examination. There was normal attention, no ectasis, no pedal edema, papillary edema was present. There was no cranial nerve or motor deficit. Sensory system was also noted to be bilaterally symmetrical. So in summary, this is a middle-aged gentleman with fever, jaundice, and abdominal distension in the background of history of chronic alcohol consumption. Examination revealed pallor, icterus, and moderate ascites with palpable splenomegaly. There were no features of there were features of chronic liver failure in the form of loss of axillary and pubic hair, mild palmar edema, ascites, and no features of right ventricular congestive cardiac failure on examination, and no evidence of GI bleed. Clinical diagnosis was noted to be decompensated chronic liver disease induced with signs of liver cell failure, not in encephalopathy, with probable spontaneous bacterial peritonitis.
So your diagnosis is chronic liver disease.
Yes.
So I'm saying this is a cardiac failure. So how will you argue with me?
So there's no elevated. There was no on examination, so there was no elevated jugular venous pressure. There was
Okay.
and there was no
From the history, you should go. Okay. So
history. He did not complain of any orthopnea or PND. There was no history of any preceding chest pain or diaphoresis, and
okay. Okay, fine. So I'm saying this is a nephrotic syndrome.
For that, there was no history of any facial puffiness. There was no history of any frothy urine which he was passing, sir, and there was no history of upper limb swellings as well.
Okay. So this is a patient with ascites, basically, isn't it? He came with ascites with abdominal pain, isn't it? So how will you approach ascites? Because what are the causes of ascites? You'll have to start like that. Okay. What are the causes of ascites? We have already mentioned two causes. So always in medicine, you should classify. Otherwise, there is no thinking process. You'll have to say whether it depends on whether it's a transudative or exudative. But clinically, we can't classify like that. But you should have a list. At least you should tell me what are the transudative, what are the exudative.
Transudative causes could include chronic liver disease with portal hypertension causing ascites. Second is cardiac failure with right ventricular failure with ascites. So third could be nephrotic syndrome which can or CKD, chronic liver disease, which can present as ascites, nephrotic syndrome.
Okay. What is Meigs syndrome? Meigs, what is that? Meigs,
Ovarian,
Meigs syndrome.
ovarian malignancy, which
Meigs syndrome is what? What?
ovarian malignancy.
Is it transitive or exudative? So ovarian malignancy, ascites with, so transudate or exudate. Transudate or exudate?
Exudate.
See, I'm trying to confuse you so that you will remember. Is it transudative or exudative?
Exudative, sir. Exudative.
It's a transudative. Okay. So it's a malignancy, but it's a transudative. Okay. So common cause of exudative?
Intra-abdominal malignancies,
Abdominal malignancies and
tuberculosis.
tuberculosis. Okay. Yeah, it should be faster. So here the evidence for, is it transitive or exudative? What do you know?
On history, transudative.
Because there is pain. If it is liver disease, you pay. Because there is pain, you suspect what?
Spontaneous vital peritonitis.
SBP. Is it transitive or exudative?
Exudative.
Okay. It's a transudative. In that there is infection. That's all. Okay. So basically you should look for more. What do you look for when you do tap? What do you look for in the tap?
Clouding.
How do you prove that it is SBP? Spontaneous bacterial peritonitis. How do you prove? Counts of? Counts means which count?
Total WBC count with a neutrophil count of more than 250.
Neutrophils of polymorphonuclear neutrophils of more than 250. Okay. And culture showing uni organism. What are the commonest organisms?
Gram-negative bacilli, E. coli.
E. coli, gram-negative bacilli or gram-positive cocci. Okay, right. So here this patient has ascites. So first of all, you're thinking is it cardiac? Is it liver? Or is it renal? Can lungs, any problem can cause ascites?
Empyema, lower lobe consolidation.
Lungs, anything can cause ascites. What is carpulmonale? Carpulmonale is? Hey, someone should answer. Yeah. Okay, it's a predominant, it's a primary lung disease causing secondary right heart failure, and they can also present with a. Okay, so all organisms can present with ascites. But why do you say this is? I'm saying this is cardiac. In the general examination, what is the one thing which can quickly differentiate between cardiac ascites and liver ascites? In the general examination, quickly you see that, okay, you decide, right? This is cardiac or this is liver. Icterus. You don't get icterus in cardiac ascites? What is cardiac cirrhosis? Okay. Anything? Which is the one thing?
JV.
Yeah, correct. You should look for JVP. Okay. JVP will be elevated in general examination, I'm saying. So first thing, I quickly go examine, is the JVP raised? The JVP is raised, it can get raised JVP slightly, even with liver disease because of the ascites. But if it is significantly raised, then it is not liver. So here, the left atrial pressure is sorry, right atrial pressure is high. So it is, it's a volume overload state. Whereas liver is a volume depleted state. So, okay, so that's how you should quickly, when you want to rule out cardiac from this thing, look at the JVP. The JVP is not elevated, it's most probably liver disease, especially you have these histories. So you should confidently say that. And you know, the another important finding in this patient is what? Splenomegaly. Okay. And your liver size is?
Liver span noted to be 10 centimeters.
10. Is it normal or abnormal? Normal liver span is?
10 to 12 centimeters.
It's a normal liver span.
11 to 12 centimeters.
Okay.
11 to 12 centimeters.
These are basic questions. Anyway, we don't go into the theory part of it. I think it's 9 to 11 centimeter. Okay. So here, what are the, you have looked for all the other features of liver cell failure.
Yes, sir.
You have looked for it. So the portal hypertension, I'm sorry, this ascites is a sign of liver cell failure or portal hypertension?
Portal hypertension. Portal hypertension.
Okay, it can be both. Right. Did you look for engorged veins?
In the abdomen, there was no engorged veins, sir.
Okay, no engorged veins.
No, sir.
Okay. So that will suggest what? If there is enlarged veins.
Caput medusa could be. Virus, caput medusa.
If there are engorged veins, what does it suggest?
Portal hypertension.
There is a portal hypertension.
Stunting.
So another question they may ask in the exam, where all you get portosystemic anastomosis. Which are the areas? How many areas? 5. Which are the areas? And which is portal, which is systemic? You should know. Okay, you should be very thorough. There are 5 areas, lower end of esophagus. Where else? Bare area of the liver. Intraperitoneal. This thing. Around the umbilicus and rectum. And you should know which is portal, which is systemic. All these things should be thorough. Okay, which are the areas you get portosystemic anastomosis, and which is portal and which is systemic. So this patient has ascites.
Yes.
There's no evidence of portal hypertension. Splenomegaly. It's evidence of what?
Portal hypertension.
So he has evidence of portal hypertension or not?
Yes, sir. He has evidence, sir.
Okay. So he has evidence of both cirrhosis, liver cell failure, and portal hypertension. Okay, now how will you manage this patient?
First, we will rule out any.
Okay, just to stimulate you, I will tell you, if you are working in a resource poor hospital, I will give you 3 investigations of choice. Now, which one you will choose? Ascitic tap, what else? Ascitic tap, ultrasound abdomen, and LFT. So LFT, liver cell, sorry, ultrasound abdomen and ascitic tap. See, here you will do everything. That's okay. So when you do too many investigations, you don't think why you are doing. That's why I'm asking this question. So 3 investigations are allowed. Which one you will choose? LFT, ascitic tap, ultrasound abdomen. You tell me.
LFT.
You do LFT. And what will you look for in LFT?
Albumin, sir.
Okay. You look for albumin. So what information you get?
The albumin is low. It means that is in the synthetic function of liver is.
How do you know this is liver? I'm giving you 3. So this patient has hypoalbuminemia. That's all you know. There are so many causes of hypoalbuminemia. So how do you know it is? Anybody else? Ascitic tap. So what will you look for in ascitic tap? SAG, transudate or exudate. Will you give a result? So even if you are working in a resource poor hospital, you need ultrasound to confirm the diagnosis. You get wealth of information, not only the liver size, splenomegaly, any other cause. So this thing, ascites. Okay, so just because you're working in a resource poor hospital, you cannot just go by this. These kind of patients, you have to do ultrasound abdomen to confirm the diagnosis. Okay, right. So now you have confirmed this is a liver disease. Okay, from your investigation, you have done an ultrasound which is showing this thing. How will you manage this patient?
So we'll generate.
So you have done an ascitic tap. It also shows SBP. So how will you manage? So this is a compensated liver disease or decompensated liver disease?
Decompensated liver.
So what are the evidence of decompensation in a patient with chronic CLD? So one is you said SBP. Anything else? What are the other evidences of decompensation you will look for?
GI bleed, which is
Gastrointestinal bleeding,
hepatic encephalopathy.
variceal bleed, okay,
Hepatic encephalopathy.
encephalopathy. Yeah, anyway, SBP. We look for why suddenly somebody goes into decompensation. What are the causes?
Any infection which can.
Okay, first is infection. Any infection, usually the GI infection, or it can be urinary tract infection. What else?
Second is
Suddenly go for decompensation. Why suddenly they are going into decompensation? So one is infection. What else? History wise, heavy drinking, heavy consumption of alcohol can push anybody to decompensation. And acute hepatitis can be any reason. So like especially drugs, hepatotoxic drugs. Okay. And any electrolyte, especially hypokalemia. But even then, 50% of the patients, you may not get any evidence to show why he has gone into decompensation. Okay. So here, this is a decompensated liver disease. You understood? Now, how will you manage this patient? Give me the priority of your management.
because he has an SBP, sir, we will start.
Okay, first thing is to the precipitant for his acute decompensation. So probably the SBP. So you will start him on
Antibiotic.
yeah, because the result may take time. So you cover for especially gram-negative bacilli, and after the culture, you decide about the thing and what else.
We'll give high protein diet for general management. Then we can give diuretics to reduce the ascites. Then we have to give lactulose syrup so that they will.
So diuretics also don't say diuretics. It should be potassium sparing ones. Okay, because hypokalemia is a risk factor. So potassium sparing, monitor the potassium properly. Okay.
Yes, sir. Then we will give lactulose syrup so that he passes daily at least 2 to 3 episodes of stool so that to prevent the complication of hepatitis.
Okay.
Encephalopathy.
That is for encephalopathy, no?
Yes, sir.
For ascites. What's the definitive treatment for ascites? Or treatment for intractable ascites? Yeah, mainly shunt surgeries. Okay. So there's splenorenal, renal, and all that. But now currently they have these tips. So, okay. And what are the complications of CLD? You already told, complications. Encephalopathy. Then come down. Always start from below upwards or above downwards. Then you will not miss any. So above downwards, then capillopathy, then lungs. What do you get in the lungs?
Pleural effusion.
Hepatopulmonary syndrome. Then esophagus, where he says bleed. In the liver. Again, coagulation disorders. All the vitamin K dependent factors produced by the liver. So coagulopathies. Then ascites, you get SBP. Okay, and renal, you get hepatorenal. Okay, so above downwards, if you go, you will not miss anything. Okay, so this patient, what are the advices you give?
First, the advice we'll give is to stop alcohol consumption.
Okay, the first and foremost thing is you should have an abstinence. And
Yes, sir.
any other investigation, urgent investigation you will do?
AFP will. AFP we can alpha fetoprotein.
Alpha fetoprotein.
Or BPV.
Okay. You do a scopy, no? You do a scopy to look for any varicose, because that one will kill the patient. So you should immediately do that. Okay. Any bleeding profile? These are the things you should do, and they should stop alcohol. Okay. See, they can go into any direction when you get this thing. I have given you a broad approach, but they can pick up one line and they go and ask several questions. So CLD will have to be very thorough, because in CLD itself they can go into they go into portal hypertension, the management of portal hypertension, complications. Okay, they can just take ascites and go into one thing. Hepatorenal syndrome or pulmonary syndrome. Okay, so ultimately, what is the treatment for him? Liver transplant. So liver transplant, hepatopulmonary syndrome, will it improve? Okay, everything will improve. All right, everything will improve. So liver transplant is the definitive treatment for him. Okay. All right. Any questions? Any comments, Ramya? Ranju and Thomas? Jonathan, you want to say anything? I have to go. So thank you very much for adding, my general comments. Please don't take it personally, because I am somewhere sitting, so I'm just coming and assessing once in a while. Please, you may see a lot of patients and all that, but you should have the theory background. Without having theory background, you will not think properly, and always have lists of things and then apply. And the thinking process you need to improve, because nothing is straightforward. Everything is sometimes complicated. So you have to think in all the lateral thinkings, everything should be there, and be confident. This was not confident at all to me, because we are all going to become physicians. So when you present, you'll have to be really confident. Okay, without confidence, how confidence will come? Something should be there in the upper story. Otherwise, confidence won't come. So try to improve your knowledge. Yeah. Any comments from your side? Any questions? Chachila. I don't know your names. What is your name? What is your name, man? Who is an intern? Oh, thank you for your interest. Okay. Okay, thank you very much. Thank you.